3 Clinical Cases of TSI Stroke Applications Part 1, number 1620, 5/2026, Gerald C. EclaireMD Foundation, Category, Stroke Risk. Special note, this research journal is based on my personal research using data from my own body and is provided for educational purposes only. It does not constitute medical advice and should not be interpreted as guidance from medical professionals. Preface. This morning, I participated in a 1OK walk in Honolulu, along Ilamona Beach toward Waikiki and back. This event is personally meaningful to me. It has been about 10 months since my stroke on June 21, 2025, and this walk served as a simple but direct test of my physical recovery and endurance. I was not trying to achieve speed or performance. My goal was simply to join the marathon, complete the distance steadily, and observe how my body responds under a controlled condition. Even though I used a cane to improve my stability, the fact that I was able to participate in and complete a marathon after a severe stroke carries deep emotional meaning and serves as a personal reward to myself. Since 2010, starting from a 5K event in Abu Dhabi, I have participated in about 7 similar walking or marathon activities in different cities around the world. Today's event is different because it represents a checkpoint in my stroke recovery process. Completing this 1OK walk is not only a physical milestone, but also a confirmation that my body still maintains a certain level of stability and adaptability. After finishing the walk, I felt calm and steady, and I quietly acknowledged that my perseverance has returned to a functional level. In this article, I will use today's event as a starting point and connect it with my past 8 years of TSI-based longitudinal data as the primary reference. In addition, I will include comparison data from my wife, with approximately 45 days of C records, and my son, with 16 months of C data. This provides an N=3 clinical style dataset to examine the consistency and usefulness of the TSI stroke concept across 3 different individuals, 3 time durations, and pathophysiological conditions, although the sample size is small. This longitudinal depth and cross-case comparisons still offer meaningful insights into system behavior and validation of this stroke risk model. Introduction. Before starting the walk, I intentionally consumed 1 banana as a simple source of allowing glucose to be cleared from the bloodstream without relying on normal insulin function. This confirms that physical activity serves as a direct and effective tool for regulating glucose without relying on medication. In parallel, I also measured my blood pressure before and after the 1OK walk, focusing on systolic blood pressure SBP and pulse pressure PP, where PP is defined as SBP minus DBP and serves as an indicator of vascular stiffness. My SB changed from 109 mmHg to 108 mmHg, and my PP decreased from 45 mmHg to 43 mmHg. These changes are small in magnitude, but they are directionally consistent with reduced vascular load and slightly improved arterial elasticity. The contrast between the before and after walking measurements, along with the differences between glucose and blood pressure responses, is important for understanding the underlying vascular health condition of my health system. Glucose represents a fast-changing variable that can respond within minutes to hours, while blood pressure, especially pulse pressure related to vessel stiffness, reflects slower structural characteristics that typically require longer periods to show significant change. Furthermore, these minor improvements could be partially offset by the natural effects of aging. Therefore, a large glucose reduction combined with a small but favorable shift in pulse pressure provides a consistent picture of TSI stroke cyst behavior, rapid metabolic adjustment alongside gradual structural adaptation. This single event can be viewed as a simple but well-defined input-output experiment. The banana serves as a controlled glucose load, while the 1OK walk acts as a mechanical intervention. The observed results demonstrate that my body system remains responsive, despite having type 2 diabetes for over 36 years. My body is still capable of handling metabolic stress and can move toward a low-risk state under appropriate control actions. My TSI stroke case. The first case is my TSI stroke analysis, based on longitudinal data starting from August 1, 2018, when I began using the CGM Libra system. Since then, I have collected about 96 glucose data points per day, forming a continuous data set over nearly 8 years, from 2018 to 2021. The TSI stroke curve showed elevated levels, with peaks between 110 and 119 dangerous range. Despite these high values, I did not experience a stroke, likely because my cerebral microvessels had not yet reached a critical level of calcification, and aging effects were less severe at that time. Around age 70, the TSI value then declined to its lowest level, about 81 within a relatively safe range, in early 2022. However, starting in January 2022, it began rising again over the next 3.5 years, reaching a level of about 105 in May 2025. After a brief decline, another elevated level around 102 appeared in late June 2025, when I experienced a stroke in the Pontine region. This type of stroke carries a high mortality rate of about 50% to 80%. And I was fortunate to survive after the stroke. My TSI values declined and have since been maintained below 100, indicating a low-risk state. The TSI-Stroke reflects the combined effect of three input factors: long-term glucose-driven vascular damage, calcification from high glucose, increased vessel stiffness due to aging and metabolic stress, and an acute hypertension trigger on June 21, 2025. In my case, although I am not a chronic hypertension patient, my systolic blood pressure briefly spiked to 175 mmHg around noon on the day of my stroke, likely causing one of my brain microvessels to rupture. Since then, I have monitored my blood pressure 20 to 24 times each day. I do not rely on average values, since averages can hide critical spikes. My focus is to capture and respond immediately to these short-duration peaks. When I detect rising trends, I intervene immediately through emotional calming, slow walking while listening to soft music, or controlled breathing, such as a 4-second inhalation followed by an 8-second exhalation, repeated 4 to 5 times, which can reduce my blood pressure within minutes. Different variables operate at different time scales. Blood pressure changes within minutes, glucose within 10 to 15 minutes, and body weight over 4 to 6 hours. This multi-scale behavior follows patterns described in wave theory, where frequency and amplitude differ across variables, and managing their interactions through multiplication rather than addition is key to controlling overall risk. My wife's TSI-Stroke case. My wife's TSI-Stroke curve shows a concave downward trend, gradually decreasing from about 98 to 94. The short-term 90-day moving average suggests a stable and slightly improving condition within a relatively safe range. Below 100, the main limitation is her data availability. She currently has only about 45 days of usable data. Although she uses the same CGM Libre system, the Libre CGM data storage is limited, and the vendor frequently changes data formats, making automated data transfer into my customized medical AI software on iPhone inefficient and unreliable. This limitation in her glucose data highlights a broader issue in current medical data systems, where different vendors use different formats without standardization or coordination. After spending considerable time dealing with these issues, I decided to switch to manual data entry. Manual entry, although time-consuming, offers a practical advantage. By entering the data myself, I can directly observe values and recognize patterns and trajectories in real time. This process reinforces my data interpretation and pattern recognition, allowing early detection of trends even before formal analysis. However, this approach requires both patience and discipline, which most users do not have. As a result, despite having CGM data, much of it becomes unusable in meaningful practice. Despite my wife's much longer history of daily blood pressure data, her glucose data collection only began about 1.5 months ago after my encouragement. I advised her to focus on 4 key time points, such as early morning fasting and about 2 hours after each meal. Based on my prior analysis, 4 key data points per day can approximate the full 96-point CGM dataset with only about less than 5% difference. Although she is not yet consistent with 4 daily measurements, even 1 to 2 entries per day is far better than no data. With the current 45-day dataset, I can only observe a preliminary trend. If she continues this habit for another year, I will be able to establish a much clearer and more reliable understanding of her stroke risk behavior. This is part 1.